importantly, let's talk about today. We are in for a treat of having three of our own Johns Hopkins faculty who are collaborating on work together, comprise a panel for today's seminar. The first speaker will be Dr. David Dowdy, who is an associate professor in the Department of Epidemiology in the Bloomberg School. He's an infectious disease physician who does interdisciplinary research at the nexus of infectious disease modeling, health economics, operational and implementation science, as well as classical epidemiology. He has done work on modeling and economic evaluation of TB and HIV and a lot of work on implementation science. The second speaker will be Holly Taylor, whom I imagine most people in the audience know. Holly is both a core faculty member in the Merritt Institute and an associate professor in the Department of Health Policy and Management here at the Bloomberg School. She is trained and brings to this project her expertise as a social scientist. She uses qualitative and quantitative methods to explore many ethics topics, most particularly in human subjects research. She's doing a lot of work otherwise on informed consent and central IRBs, and then again we'll hear about this work related to MDR-TB. And then, last but not least, is Merritt, also known, I imagine, to many of you in the audience, also like Holly, a core faculty member of the Merritt Institute of Bioethics, and also an associate professor in the Department of International Health here in the Bloomberg School. Mariah's work focuses on social justice impacts, along with cost-effectiveness, as she looks at economic evaluation in various policies. She has long-standing interest in the ethics of public health research in low and middle-income countries and also in moral psychology. So the panelists have assured me that they will keep their own time. The plan is for all three of them to talk, and they said that we will also have time to ask questions again at once. So David, particularly welcome graduates in the Merritt Institute Seminar.
So it's a pleasure to be here. If I don't have much of a voice, I apologize. I was giving a lecture to our Epi Methods course earlier today and then leading an Epi Lab, so it's been a bit of a busy day, especially for my voice. I'm pleased to have a chance to talk to you guys. It's actually a real treat for those of us who don't live and work in the world of ethics all the time, but interface with you guys a lot. And so I'm going to lay the groundwork behind a project that I've been doing with Mariah as our fearless leader and Holly to look at incorporation of social justice into economic evaluations of novel drug regimens, or MDR. So I'm going to start by laying out the problem and why this is something that we need to be evaluating. And then Holly's going to talk about how we are planning to and have already started to collect data to inform this question. And then Mariah is going to talk about the philosophical aspects as well as the linkage to economic evaluation at the end. And we will have time for questions as well. So just so you guys all know what we're talking about, and so that I can sound like I know what I'm talking about, I'm going to tell you a little bit about multidrug-resistant tuberculosis. So TB is generally treated by 4 drugs, rifampin, isoniazid, ethambutol, and pyrazinamide, the 2 most potent of which are rifampin and isoniazid. MDR-TB is TB that is resistant to those 2 drugs. There are over 500,000 cases estimated to occur newly each year, of which only about a quarter are actually notified to the public health authorities, and it's very difficult for people to be appropriately treated for MDR-TB without being notified, so it's probable that only about a quarter or less are being appropriately treated. And we believe that probably half of these individuals ultimately are dying. So treatment for MDR-TB is particularly burdensome, onerous. And I think that understanding this is really critical to understanding why we're interested in this as a potential venue for evaluating social justice and economic evaluation, because this is something that does not just affect the economies of those countries that have to pay for this, it really impacts people's lives. Right? So if you have MDR-TB, you can, at least currently, anticipate receiving 2 years of treatment. And there's this little infographic here that's a total of 14,600 pills, right? If you were to stack up those pills end to end, it would be the height of the Golden Gate Bridge, right? So this is a ton of medications, right? And I think that any of you who've had to take medicine for any sort of chronic condition, say it's hypertension, right? If you and think about how easy it is to miss some of these drugs, right? And imagine if you had someone there every single day saying, you have to take these pills, right? And it wasn't just 1 or 2, it was a handful of them, right? And it wasn't just a handful of bland pills that did nothing to you. These things made you feel ill, right? That 3 out of every 4 people have nausea, right? And they know it's the pills that are doing this to them, right? 15% of people who take these drugs lose their hearing, specifically for high pitches, right? And so they become unable, for example, to appreciate music or the inflection in people's voices, right? So this is a treatment that is not just expensive, right, and not just difficult to pay for. It really affects people and their lives. We are starting to do better with this. So this is a very active area of research. The TB world knows that this is a problem, right? There's a problem in that the pharmaceutical industry does not see a market here, right? And so it's very difficult to expand new TB regimens. But we are working on this, right? And so, yeah, this is not, these pointers never work very well, but does this work? That's all right. So up in the upper right-hand corner here is just an illustration of what these regimens entail. So there is a new regimen that is, rather than 2 years, it's 9 months, right? And the initial 2-year regimen requires 8 months of daily injections, right? So every day you're going in and getting poked in the butt, basically, right? So the new regimen has reduced those 8 months down to 4 to 6, but it's not eliminated those. And you can see that the new regimen, which is over on the right-hand side over here, right, while it is shorter, it actually involves taking even more drugs during that time. So it's not like this new regimen is something that's just wonderful, okay? It has other side effects, like it makes people's skin turn bronze, for example, which some people really like, but some people really don't. But it's hard to hide the fact that you're taking this regimen, for example. There have been modeling studies that suggest that using this shorter course regimen, because by being cheaper, it could be scaled up to more people, could substantially reduce the incidence of MDR-TB. So these are projections of MDR-TB incidence now and into the next 15 years. These are projections of what it might look like if we were to scale up this regimen. So there is hope, right? But we are not where we need to be. And I think what we are trying to do partially here is help to make a case for doing better even than this new regimen, right? So while we're getting better, we still have a long way to go. So switching gears so that everyone's on the same page as Holly and Mariah come after me, I want to talk about economic evaluation, because one of the key issues that people have raised about these regimens is that they're expensive, right? So the average regimen, the current regimen, probably runs about, in most places, $3,000 to $5,000 per person. In the United States, treating one person who has MDR-TB costs the health system about $100,000 per person. So it is expensive. And some people would like to evaluate these novel regimens on the basis of cost effectiveness, right? And so economic evaluation, which includes cost effectiveness analysis, is the process of systematic identification, measurement, and valuation of the inputs and outcomes of two alternative activities. For example, current TB treatment and a proposed hypothetical new MDR TB treatment, right? And then the subsequent comparative analysis. So to look at people who are taking the current regimen, what those people might look like if they were taking the new regimen, right? And in cost effectiveness analysis, which is a subset of economic evaluation, we are actually creating a ratio of cost to effectiveness, okay? And if that effectiveness is measured as Dowdy's or qualities, that would be considered a cost utility analysis. So classically, how we might go about performing a cost effectiveness analysis of a new TB drug regimen would be to take individuals who have TB or in this case MDR TB and say and evaluate what their outcomes might be under the standard regimen versus under the new regimen. And we can apply probabilities to each of these various things. So what's the probability that this person would adhere for the first 2 months, that they would be lost to follow-up, that they would die? They would adhere for the next 2 months, lost to follow-up, and die, etc. You can calculate out the probabilities of all of these outcomes until at the very end, basically everyone has either been cured or died or continues with TB, right? And you can then compare what are the expected outcomes under the standard regimen, what are the expected outcomes under the novel regimen. And for each of these, you can assign not just an outcome, but also a cost, right? So for someone who is assigned the standard regimen, adheres for 2 months, adheres for 4 months, completes the regimen, then recurs, and then ultimately survives, you can calculate, you can estimate using data from the literature or data that you collect directly, what the cost of that particular branch would be. You can estimate what the probability of that particular branch would be, and then you could say what is the expected overall average cost, overall average effectiveness for the standard regimen versus the novel regimen. Does that make sense for you guys? If you're all following me? Okay, great. So, and then what we usually will do is to evaluate the incremental cost effectiveness versus the old regimen, right? And that's done traditionally using an incremental cost effectiveness ratio. So we would take the expected cost of the new regimen over all of these average people minus the cost of the old regimen. So what does it cost to go from the old to the new, right? And the effectiveness in the same way. What is the effectiveness that we gain going from the old to the new, measured as numbers of years of life gained, or Dowdy's averted, or TB cases averted, whatever you want that effectiveness measure to be, right? And you can say what would then be the cost effectiveness, the cost per outcome achieved, right? And again, a typical metric is the cost per Dowdy averted, so disability adjusted life years averted. So that's equivalent essentially, without getting into economic theory, of one high quality year of life gained. How much would you be willing to spend for that, right? And a typical metric is the gross domestic product per capita, right? So the idea being that if you can pay enough to get 1 year of life back, high quality life, the least that person could do for society is just go back to work, right? That should be like the minimum floor. That would be a highly cost-effective intervention. And just to say, this has been done for novel MDR TB regimens. Here, RR means rifampin-resistant, but rifampin-resistant MDR, very similar. So, and in many cases, right, the incremental cost per Dowdy averted is estimated somewhere between $50 to $500, which in most cases is well below that threshold. And I don't want to get too much into the economics of thresholds and such, but all this to say that this sort of analysis has been done, and in general, it looks like new regimens are likely to be fairly cost effective, right? But what we're going to talk about today is what's missing from this, right? So in other words, if I take, and I'm going to compare a new regimen to an old regimen, and I'm just going to say, here is the incremental cost per Dowdy averted. And this new regimen would cost $500 per Dowdy averted, right? What's missing, right? And what's missing, right, is this, right? This story of what's happening to people who are having to take these regimens, right? And not just in terms of how would I rate my quality of life on a scale from 0 to 1, but how does this impact my interactions with society, right? How do I experience advantage, disadvantage within society as a result of having to take these new regimens, right? And so what we want to do is not to discount the importance of the classical economic evaluation, but to bring this in as well, okay? And so with that, I'm going to hand the baton to Holly and let her talk about how we're collecting data.
Thank you, David, and thank all of you for coming. I also just want to say that as you'll appreciate by the end of this session, it's been a real privilege to work with Mariah and David on this, and I want to acknowledge Allie Searle, who's our intrepid project coordinator, and it's a really fun, interesting, engaging project, and one I hope to, having the three of us in a room is a really fun thing for us, 5 minutes. So as David said, I'm going to sort of transition to what we know to what we might like to learn more about. And this is a depiction of our specific aims, and I'm going to focus on the top left there, the empirical aim, but just want to give you a sense of where we're headed. That Mariah is going to step in a moment and speak a little about the core framework for social justice, and then how the product of bringing those two things together is going to be what we're referring to now as a social justice assessment to frame or to embed the CEA that David was describing. So here are generally the primary aim for our empirical project. So how does diagnosis and treatment for MDR worsen or not the extent of disadvantage that patients experience? Ways in which MDR treatment may compromise agency, respect, and association. And you'll hear those words again from Mariah as we talk a little more about social justice. And are there any local or cultural factors that may be relevant to the life experience of MDR-TB patients that is not usually included in an epi report of here's how many people were treated, here's how many side effects, here's how many people had nausea. What does it really mean to have nausea every day? What does it mean to have these injections every day? For many people, it means a lot of pain, and it gets in the way of their walking to the clinic the next day for the injection. So we want to be able to think about how to incorporate things like that into this assessment. So how do we do that? What we decided to do was to do 3 site visits. And in each of those visits, we do in-depth interviews with those familiar with the direct and aggregate experience of MDR-TB, and I'll clarify that a little in a moment. And really importantly, and I think Mariah can endorse this as well from this work and previous work we've done together, the power of the direct engagement with place and people, especially when you're trying to get the, what does it really mean? It's hard to get that from the answer to a survey. It's very powerful to meet someone in a building where they usually are and talk to them directly about their experience. It's just a wholly different thing, and I think would be really hard to do this work without having that personal experience. So as I said, we're interested in perspectives on patient experience. So obviously, perhaps, we're talking with patients who have experienced MDR-TB and MDR treatment. And then we also wanted to get what we're referring to as sort of aggregate perspectives, both from providers who care for those patients and engaging with people who have MDR-TB in their neighborhoods, in their churches, in their communities. So during the site visit, we are conducting interviews with all of these folks. Our first site visit was to Cape Town. Mariah and Allie are currently planning a second visit to Johannesburg, but I'm just going to tell you a little about our Cape Town visit. So this is one of my favorite images of our visit. This is on the campus of the Brookland Chest Hospital. My back is to a small building that we had as our HQ, thanks to Grant Barron, who was a huge help to us, as was Ruth Wilson. And Table Mountain is just something you can't ignore in Cape Town. As someone who grew up in California, having a mountain and an ocean to keep myself oriented was really important, and I think I felt that too in Cape Town. It's always there, except of course when it's really foggy and you can't see it. So here are the key interview domains. I'm not going to walk through all of these, but generally we had very common domains across the three groups that we wanted to hear. What does it mean to have TB? What does it mean to be treated? What are the things that get in your way of treatment? What are the things that motivate you? And I'll say here, one limitation that we would all easily acknowledge is that we could only speak with patients who are generally adherent, generally known to clinic staff, who were willing to come and talk to us. So we basically, spoke to people who are doing fairly well because they could come to us. Better that than not. And then also another reason why we wanted to speak with providers, that they could speak about the aggregate experience and speak to those who we might not actually be able to engage with directly. And then I want to just orient you, as I can hopefully, to what we're doing next, or what we're doing now. So we did in-depth interviews with our first site visit to Cape Town, and Allie and I are engaged in data analysis at the moment, and our hope and our intent is that the product of that set of in-depth interviews will be a preliminary set of information that we can feed into the social justice assessment. So there are two things. One, we went in interested in agency, association, respect. So no surprise, our domains are related to those, and we have data that will speak to these either individually or together. The TBA there is that sort of holding place for whether there are things that we hadn't imagined we would encounter that we want to make sure we include in that social context. And then coming out the other end will be informed perspective from these site visits regarding social justice. So this is one of 3 site visits. We're excited to get our hands dirty, as it were, before we send Mariah and Allie off to Johannesburg. But I'm going to end with where I started, to hand off to Mariah. She is now going to talk about what we hope to accomplish in that middle square once we have all of our data.
Thank you very much, Holly and David, for your excellent presentations. And I also want to reiterate what a joy it is to work with both of you and with Allie and all of our colleagues on the project. And this is one of the things that gives our lives meaning, I believe. Certainly is true of me. As a reminder, this project that the 3 of us are working on has 3 specific aims. Holly just told you about aim 1, getting perspectives on the patient experience. And I'm now going to spend time on aim 2, which involves our using a previously developed core framework of social justice, which is where the categories of agency, association, and respect came from. So I'm going to walk through that at some length. We are using that core framework to help us interpret our findings on the patient experience so that we can construct social justice assessments for use in comparing MDR-TB drug regimens on the service of aim 3, the development of a prototype decision tool for performing justice enhanced CEA. And at the end of my segment here, I'll give you a preview of what justice enhanced CEA might look like. Now, I'll start by walking you through aim 2 as we conceived it initially. We want to assess the impacts of standard and novel MDR-TV regimens on core aspects of social justice not accounted for by traditional CEA using this core framework of social justice developed by our colleague from the Merritt Institute, Ted Daly, who's in the audience today. Thank you, Ted. And Fabrizio Tediosi and myself to interpret empirical findings on MDR-TV patients' treatment experiences. And then we'll use that data to construct social justice assessments that we hope will be applicable to each major type of treatment outcome. If you remember the decision tree that David showed you, we want to have a social justice assessment sitting at the end of each of those pathways. And then I'll show you how they can be compiled to inform the overall choice between the two types of regimens under consideration. Let's take a step back, however, for a moment and touch on the more general problem in public health ethics that has inspired this project and others. Now, and here I'm more or less quoting or paraphrasing from the introduction to a systematic review paper that we have under review. The lead author was Vadim Duchain, another colleague that we met at the Merritt Institute. The second author is Ali Searle, who's here today, our research program coordinator. David and Holly worked on this. Alice Swerling, who did a lot of foundational work for Justice Enhanced CEA while she was working with us before she took a job at University of Toronto? No? Ottawa, University of Ottawa. So many people have contributed to this work, and I want to acknowledge everyone's contribution. But here's the key thought, that if you want to achieve fairness in priority setting for healthcare resource allocation, it requires that you consider the distribution of health outcomes, but also the distribution of advantages and disadvantages in people's broader life experiences, and this is what we mean by social justice. If you read the article on public health ethics in the Stanford Encyclopedia of Philosophy by our Berman Institute colleagues Ruth Faden and Serene Shabaya, you'll see a discussion of the ways in which priority setting may involve trade-offs between economic efficiency, which is itself an ethical concern, and the aversion or alleviation of systematic disadvantage. Now, what David and Holly and I are doing in our project is studying this long-standing general problem in the context of novel drug regimens for MDR-TV. And to do so, we are using this core framework of social justice developed by Ted and Fabrizio and me in the context of neglected tropical diseases. The concept of the core framework of social justice has proved to be transferable to other disease spaces like that of MDR-TV. I'll tell you briefly how we developed our framework. We used theories of social justice drawn from moral and political philosophy to take account of how people experience diseases and associated public health interventions in ways not usually considered by economic evaluation. Well, precisely how did we work that out? And here, Ted deserves a lot of credit for I think, coming up with this concept. Based on, a recent trend in philosophical ethics is the use of theories of justice that are based on multidimensional metrics of well-being. Well-being is how well someone's life is going for the person whose life it is. The idea of this family of theories of justice is that people who have many different worldviews, many different forms of life experience, many different value systems, nonetheless can all have reason to treat certain dimensions of well-being as matters of fundamental ethical importance, because each of them is a very basic determinant of how well their life is going. Leading theorists that we considered were Madison Powers and our own Berman Institute colleague Ruth Faden in their book Social Justice, Norma Daniels in his book Just Health, Jennifer Prauruger, Health and Social Justice, Srinam Venkatapuram, Health Justice, Joe Wolf and Avert Shalit, Disadvantage. Those are excellent books to read for this subject matter. So the approach to social justice involving multidimensional metrics of well-being has been used in the ethics of international development. In the writings of the first 4 of these author teams, it has been specifically adapted to health. And in addition, Wolf and Dowdy have used the same approach to explore the ethics of resource allocation more broadly. And the way we developed our core framework of social justice was by identifying the main areas of overlap among these leading theories. We figure, all of these authors have argued and supported and supported their theories, and have undergone tremendous amounts of peer review, have been out in the literature for a long time, have been very influential. If we can find the areas of overlap among them, that constitutes an even more robust basis for moving forward with a sort of framework of social justice for application for the uses that we're looking at in our project. It turns out the areas of overlap that we identified were, now these words will look familiar to you since Holly has mentioned them before. Agency, respect, and association, where agency is the ability to lead your own life and engage in activities you find meaningful. Respect being the recognition by others and yourself of your equal value as a human being. And association being the ability to engage fully in a range of intimate, family-friendly, community, economic, and civic relationships. And another point of overlap among all the theories was that there is a duty of justice to avert and alleviate what some theorists, such as Wolf and Dowdy, call the clustering of disadvantage across multiple dimensions of well-being. Each of the theorists talk about this in their own different ways. Powers and Faden talk about densely woven patterns of systematic disadvantage. What they all have in common is the idea of patterns in the way that disadvantages get distributed, some of which can be mutually reinforcing. So there's a vicious cycle. So if you become disadvantaged in the domain of agency, the same thing that's causing that may cause you to become disadvantaged in the domain of association, or there may be interactions across the domains, and generally you start out badly off and you get worse and worse off as a result of a certain impact, and that's what we'd like to be able to disrupt as a requirement of justice. Let's use the example of MDR-TB treatment to illustrate the core framework. So there's a document called the DRTB Manifesto, which is developed by patients and advocates for patients. You can look it up online sometime. It's very powerful. Patients tell the story of their own treatment experience. And here I'm just quoting from parts of that manifesto where they themselves name impacts of the standard treatment that David described in all 3 core dimensions of well-being, with particular attention to the consequences of these painful daily injections. We can't go to work or take care of our loved ones or go to school. Often we're stigmatized and face social exclusion. This is what it might look like for MDR-TB treatment as it's standardly provided to worsen the clustering of disadvantage across multiple dimensions of well-being. With respect to the duty to avert the clustering of disadvantage, we know that poverty and exclusion influence people's exposure to MDR-TB in the first place. So people who find themselves living with this disease were often already disadvantaged before, and the disease itself may set them back farther. Now, to be sure, a treatment resulting in cure is needed to help people survive the disease and overcome the setbacks imposed by the disease. I hope that nobody is getting the idea that we're opposed to the treatment because of the impacts that it has. We know that people need treatment. What we're concerned here is, what we are concerned with is taking account of the experiential price of MDR-TB treatment as compared on standard and novel regimens. So ideally, the treatment that's necessary to cure the disease should not itself further worsen the clustering of disadvantage for people who are living with the disease. But the patients who spoke out in the DRTB manifesto say that standard treatment does tend to do exactly that. So that is the human face of the public health issue that we are concerned with here. Now, I'm going to share with you some of the reflections on our first round of interviews that I've had, that Holly and Allie and David and I have all had as we have contemplated our transcripts. And for those of us who conducted the interviews, Holly and Allie and myself, I think often think back to the very experience of doing the interviews and being with the people who were kind enough to speak with us. On your left-hand side is the porch of the building where we conducted a lot of our interviews with patients. And on your right-hand side is one of the 2 rooms that we use for most of our patient interviews. There would usually be an interpreter sitting in that one chair, the interviewer in one chair, and the patient in one chair. Simple but comfortable. And of course, we had the windows open with a nice breeze blowing through. The patients needed to wear surgical masks to keep any infectious agents that were still perhaps in their system from getting out, although they were on treatment long enough that we weren't too worried about that they did have to wear these masks. And the interviewers and interpreters had to wear N95 masks to keep the germs from getting in. And we were worried at first that these masks might be stigmatizing, but at least my perception was that they weren't particularly stigmatizing. In fact, everybody felt like they were being socially responsible by wearing the masks, and we got used to it pretty fast, although we learned that it's important to smile with your eyes when you're doing the interview because people can't see the rest of your face. Now, one of the most important insights we gained from our interviews so far is about the advances in future treatments that patients would prefer, and the reasons they give for those preferences. For example, one patient was studying to become a professional nurse at the time of their diagnosis, and they felt that needing to be on treatment for 2 years had changed their life completely. Now here's a quotation from this patient's interview. "I was telling myself, next year I will be a professional nurse. Now I'm sick. I'm taking tablets. You sit and you think, hey, I'll be able to reach that goal. I don't know. Is the treatment going to work for me? I don't know." It's a lot of things that you think. And to see your colleagues, they are professional nurses. You are in the same class with them. It's also giving you stress. End of quote. And we would represent this as a deep impact on agency, the ability to lead your life as you wish and to engage in activities you find meaningful. Another aspect of treatment duration that some patients talked about was how it would be a great advantage to be able to say to the people they know, look, the treatment's only 6 months, it will work, it doesn't take too long to reduce the level of infectiousness, by contrast with having to tell people about a 2-year treatment on which it's widely perceived that people can't stand the treatment and are likely to default or to not keep taking it and to become contagious again and then die. That is a common perception that people have about MDR-TV treatment just because it does take so long and it is so onerous. So if you had to tell your associates that you're about to embark on this treatment, you might choose to just withdraw from your social relationships and even stay away from your job in order to avoid talking about it. One patient also spoke about getting rid of the daily injections because the pain makes it impossible to sit down. And even if people come to visit you at your house, quote, you must stand, you can't sit, it's not nice, unquote. And these sorts of experiences represent impacts on association, the ability to enjoy relationships with people that you want to be in relationships with. Another patient said they prefer a shorter course of treatment on the order of 6 months rather than 2 years because they're absolutely, quote, unquote, suffering from being rejected by their family as well as cut off from work that they find meaningful. Quote, imagine for me to sit at home for 2 years, unquote. So putting all these interview responses together, and this is just a sort of quick snapshot of the kinds of things that we were seeing in interviews, but I tried to select ones that were evocative for you. Putting it all together with respect to the typical patient experience of, say, just the 2-year duration of the standard treatment, let alone other aspects of it. That may represent a deep cross-cutting impact on both association and agency. And such findings about specific types of experiences would inform our comparative assessment of social justice impacts for the standard and novel regimens. For example, we might reasonably expect that even patients on the standard regimen who make it all the way through to cure will have to go through a 2-year treatment duration involving painful daily injections for part of that time, with cross-cutting impacts on association and agency, whereas patients on novel regimens, say less than 6 months with only pills, won't suffer those impacts. Now, they might have other things, but they won't suffer these deep impacts cross-cutting on association and agency. Now, these social justice assessments are meant to feed into the overall methodology that we're calling Justice Enhanced Cost-Effectiveness Analysis, or JECEA for short, which is represented by aim 3 of our project. Here we have a simplified example of the traditional or classic decision tree for CEA, like the one David showed earlier in the talk. Now, to turn this into Justice Enhanced CEA, we would proceed as follows. We would develop a hypothetical cohort with a set of population characteristics representative of MDR-TB patients in a specific setting, which would include a baseline estimate of the pre-existing clustering of disadvantages. What we're interested in is the extent to which the treatment does or does not make things worse than they were for the person before they started the treatment. We would then follow this cohort through the decision tree, assigning to each potential pathway a data-informed social justice assessment representing the standpoint of the patients whose treatment experience leads them down that path. And we would expect these assessments to be categorized into 3 levels, which we've color-coded green, yellow, and red. Expected not to worsen the pre-existing clustering of disadvantage would be coded green. May worsen, for instance, having a mild impact on a single domain would be coded yellow, and then expected to worsen as for a cross-cutting impact on 2 or more domains would be coded red. We hope to refine these gradations as we go along, but this is our starting point for purposes of beginning to develop the prototype. Then we would overlay those assessments side by side with the cost-effectiveness assessment and designate to each pathway a bar whose color reflects that expected to worsen, may worsen, or not expected to worsen, and whose length reflects the proportion of patients in the hypothetical cohort who would be expected to follow that path. And then we compile an overall social justice assessment, which you see at the bottom there, by laying the bars for each regimen alongside each other. And here I want to particularly acknowledge the work of Alice Zwirling, our former research program coordinator who helped us develop these graphics. The purpose of this graphical assessment is to incorporate social justice considerations into traditional CEA with a readily accessible visual impact. And without looking too closely at the details right now, the idea of this graphic is that it would be able to show at a glance that, say, as in this hypothetical example, the novel MDR regimen is preferred over the standard one in terms of its impact on social justice. And you would also have the incremental cost-effectiveness ratio displayed alongside this, and so you could look at both how cost-effective it is by these traditional measures and what is its impact on social justice. Once you have that ability to display these assessments alongside each other, then there are several logical possibilities. Perhaps in a given scenario, CEA and Justice Enhanced CEA might both support the same regimen. Like, in a given comparison, maybe the same regimen is both more cost-effective and better for social justice. Or they might diverge. In some settings, the novel regimen might be less cost-effective but better for social justice. And in that case, it isn't that this tells decision makers what to do, but rather it gives them more information to think about it more explicitly, because they already intuitively are concerned about these things, usually. So decision makers might still go with the more cost-effective option, but try to mitigate the social justice impacts that they're now aware of in specific ways. Or they might use the social justice information to argue in favor of the novel regimen, despite its being less cost-effective. I just have a couple minutes left, so I'm about finished. I just wanted to touch on a couple of ethical issues that might come up. Supposing we develop this prototype and people start using it, what are some ethical things that we need to concern ourselves with in the use of it? I can think of at least two kinds of issues. We, I think, want to perhaps do some further work to make sure that the normative foundation is as generally applicable as we hope it is or suspect it is. And there may be some unintended consequences that we need to be on guard against. Now, to take the first concern first, it is true that all the theories of justice that we've talked about to develop the core framework of social justice broadly reflect the values of Western liberal democracies, which we're painfully aware these days that not everyone accepts. And there, in some places might be good reasons for having a different set of values, which leads us to ask about the category of experience that Holly's slides labeled as TBA or other. Are there some dimensions of well-being that patients experience as fundamental that we're not able to track with our core framework? We have, at best right now, I think, a partial solution to that problem in our empirical work, which is just to ask many open-ended questions and listen hard. I think the philosophical work could still use some shoring up, and that's one of the things I want to be working on in the coming year. Might the use of this methodology work against universal access? Suppose you have a result in which the justice enhanced part of the analysis recommends a novel regimen and plain old CEA recommends the standard regimen. Some decision makers might argue for paying more and overriding cost effectiveness. Others might use the same results to argue for price reduction or generics. It really depends on who is deciding. This is a theoretical problem that I envision might occur. I just wanted to flag it as something that is interesting to think about. But I think procedurally an important part of the solution is to involve treatment activists in all of this work. Might the use of this methodology downplay structural drivers of disease and of disadvantage? We are particularly sensitive to things like structural violence in working in South Africa. I don't think our intention would be to detract from the consideration of structural drivers, and so I was wondering if we could even, in the future, adapt JECA to compare biomedical versus structural interventions. Currently, we're just talking about using it to compare between a fairly narrow choice of biomedical interventions, but theoretically, why not use it more broadly? Again, maybe the economics will work out. We'll see. It's just something I thought of. In conclusion, what we want to leave you with is the thought that impacts on people's experience of disadvantage in society ought to count in decisions about scaling up novel MDR-TB treatments. The methodology that we're developing is worth exploring. It certainly has various technical and ethical issues to be worked out, but we are enjoying working on it. We're making progress, and we hope to come up with a nice product at the end which may be transferable to other disease areas. Thanks very much for your attention. We just wanted to acknowledge our collaborators and our funding and mentoring support.
And there are now open for questions to anyone. Start with Jeremy.
Great, thank you guys for a wonderful presentation and a really exciting project. I have two questions. The first is the balance of the discussion of social justice. Almost all appeared to be in the negative. What couldn't happen, what didn't happen, what the bad effects were. Are you hearing in any of the empirical work any of the positive aspects of treatment, such as either health to self or well-being of others that I care about? And That's question one, because I think that will really give you a more robust analysis. And the second piece is thinking back to why people are being treated anyway, and how does it factor in the fact of both health to self and health to communities, figure into a more, again, robust notion of social justice.
I have to go get my pen and write those down.
So great questions, Jeremy, and I'll try to tackle this first one while Mariah tackles the second, or I'm going to make her tackle the second. So I think you're absolutely right in terms of how we've cast this and how, in some ways, we influence the way that the interviews go. That said, we ask everybody in the interviews, what's motivating them to be adherent with treatment, what do they hope for when they're done, and so we have captured that in terms of their experience, but that's all in the context of the many people who, despite being adherent with treatment with for MDR-TB, will still die. And so it's it's very thought-provoking, and I appreciate it, but it would be important to make sure that we think about that as well.
Thanks, Holly. Jeremy, could you please repeat your second question so I make sure I understand it?
I need a pen to write it down.
Well,
So what I think I said was a question of thinking about why treatment is being offered and given for MDR-TB in the first place, both to the potential health of the individual and the health of others and the community.
yeah, so I will start and then Mariah can pick up. So also really great point, and this doesn't capture the idea that you're sharing, that maybe the rest of the group doesn't appreciate, that if you have MDR-TB and are not treated, you are actively able to infect your family members, your spouse, your children, the people on the bus that you commute to work with. And so we're very aware of the community context and the importance of focusing on, it's similar to HIV in the sense of keeping that viral load down of those who have the MDR-TB, because it has clear benefits for them and also clear benefits for those around them.
Thanks, Holly. And thanks, Jeremy, for the thought there. So now I see what you're getting at. And interestingly, in the neglected tropical disease space, where I'm also trying to develop this methodology with my colleagues Fabrizio Tediosi and Simone Sutherland, we have been using a different form of analysis called transmission dynamic modeling, which takes into account the impact on the reduction of disease incidence as a result of different sorts of treatments being rolled out. And so it is possible to incorporate the health of the community into both CEA and therefore JECEA, and I take your point. Thank you. David, do you want to add to that?
Carly.
Hey, thanks so much. This is incredibly interesting and important work, and I'll probably ask a million questions of you over a longer period of time, but I have two just for right now. The first is on scalability. So it's amazing that you're going and doing these in-depth interviews, but that's very time and resource intensive, and as people are thinking about applying this more broadly, how does this become a scalable way to look at a broader range of interventions, or how do you prioritize which interventions you use this approach for? The second was, in your interviews, did you hear any internal conflicts where maybe agency was better on one, but it would detract from association, or was it across these three dimensions of social justice that you're using for your framework, where there might be these internal trade-offs, and one might be better, or one might be more important from the patient perspective, and they'd be willing to say, if they had greater agency, it's okay that they look bronze and, like stigmatize. I don't know, I just am curious how you'd handle those kinds of trade-offs, both internally and then when comparing between standard and novel.
So I can take the second one, the first part of the second one. The second part is challenging in question in terms of, you know, in our coding, in our products of our coding, can we track whether things fall into multiple buckets as they are considered, you know, in the analysis? And really quick on the first, yes, right? And we've been aware of that since, you know, Mariah came up with the idea for the grant in the first place. And so two things. One, we know it's challenging to be scalable. That said, I think one of the products of our work will be some sort of recommendation about how one might focus on collecting certain types of data that may be relevant to a comparison such as this in terms of the old versus the new. So we're not going to say you must do a month-long site visit before you do it, but these are the most important things you ought to try to capture.
Thank you, Holly, and thanks, Carly. A further thought on your second question, Carly, about trade-offs across the domains of well-being. Remember, Ted, when you and Fabrizio and I were writing this earlier paper, one of the things that we remarked on in the paper was the idea that even compelling people to make that kind of trade-off was in itself an impact, right? So they might choose to resolve it in a way that works for them, but ideally they wouldn't need to. So, for example, some of our interview respondents would say that because of the perceptions of people in their neighborhoods, when they would walk along the street, they would they would expect to run into groups of people, not necessarily their friends, but people who knew them, who would say, "Oh, you know, you're going to the clinic for TB treatment. You probably won't be able to continue it. You're going to die." And you know, naturally, you want to avoid that. It's a form of disrespect, stigmatization, just in virtue of going to get your treatment. And so people might choose to, you know, take a different route at great inconvenience to themselves in order to avoid that contact, thus to some extent compromising their agency. So you get the idea. People do experience, I think, things that might be characterized as those trade-offs, but I agree with Holly that we need to be very meticulous in our analysis when we attribute trade-offs to what people are saying. Do you think that?
Depends on how many questions we have. I mean, I think to the scalability question, I think part of this is also like we're just trying to see if this works, you know. And so if it does, then that can motivate in the future these questions of this is something we should try to scale up.
Yeah, Ted.
Thank you guys for what's really an exciting project that speaks to everything I'm interested in. So I'm very interested to see where this goes, and I'm very excited about where it's been. Was going to ask a little bit about the TB-specific characteristic of this, because it's being used as a model disease to sort of explore and implement and operationalize this. But there are some things about it that are, like any disease actually, specific to it. And one of the ones I'm curious about how it's come up or how you envision it coming up is the role of compulsory measures. So TB, unlike say trypanosomiasis or soil-transmitted helminths, is subject to compulsory detention, isolation, and a number of other, even compulsory testing. So there's a number of really liberty-limiting public health measures that are somewhat uniquely justifiable under existing legal and human rights regimens. And I'm interested in how those norms, say the norms by which we limit people's liberties as a government, and other governments too, and also human rights standards as set when we can derogate civil and political rights, how that might factor into the evaluation of these alternative regimens. Because when you mentioned that some people that we're not looking at, you're not looking at are defaulting, or that we're not looking at those people, are those the people who then subsequently become subject, say, to institutional detention or longer periods of isolation at home?
So the quick answer is, in South Africa, there is no detention whatsoever because of their, human rights milieu. It's just off the table. So there is no compulsory treatment for TB or MDR-TB. We are also going to be doing a site visit, or our plan is to do a site visit in Uganda, and so it'll be really important for us to understand what that context is before we go in as it relates to detention. But where someone would say, well, of course, we can't make them, you know, follow their treatment. So it came up as something people would sort of say in passing because of the context.
So, I mean, I'll say also just, since TV is my thing, right? So, I don't think, I mean, in many parts of the world, I don't think that the compulsory nature of the public health response is a strong motivating factor. Now, when we're talking about the former Soviet Union, for example, I think this is a different story. But in most of sub-Saharan Africa, I think it's not a major contributor. But in some ways, I actually think this is a strength, because the same characteristics of TB, namely that it's an airborne infection. It's not even like I have the flu. It's like if I'm coughing over here, people who come into this room 3 hours later are at risk, right? And people feel this, right? It is a community disease. It is a social disease. And so in some ways, I feel like it actually speaks to why this is the model condition for an analysis of social justice.
So I think I'm sorry to say that it is 1:15 on the nose and we're going to need to stop, but you know how to find these people. They're local, so if you have more questions, find them, and let's thank them for